So when you break down fatty acids, your goal is to get acetyl-CoA, which can go into the citric acid cycle, and then you can use it as energy, just like you would with, say, glucose. But when you are low on some of the intermediates, you shunt them instead into ketone production. This is kind of like with glucose. When oxygen's around, you run into the CCA cycle, and when oxygen isn't around, you produce lactate. This is sort of analogous.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm one of your hosts, Dr. Cyrus Nick.
And I'm your other host, Dr. Nick Mark.
Nick, how are you doing today?
Good, man. I just spent 2 hours investigating Punxsutawney Phil, the famous groundhog meteorologist. I wanted to look at the stats and see how he compares to, just like a coin flip.
He's pretty bad, isn't he?
No, he's actually way better than a coin flip.
Really?
If you predicted 6 more weeks of winter every year, you would do about as well as he does. He predicts winter 86% of the time, but it's interesting. It's just a good reminder that, whenever we think about any diagnostic test, right, we should think about, like, how does this compare to a test that is a mindless groundhog?
Duly noted. While you were researching Punxsutawney Phil, I was cycling between several different audio sources until I finally was able to find the one that worked best for my current environment, not being in the usual studio, quote unquote, aka the guest bedroom at my house. Both of us were kind of on our own kind of quixotic journeys, so to speak.
Indeed. Well, what are we going to talk about today, man?
Yeah, so this is an episode that's been long in the making, and I take a responsibility for the delay in getting it off the ground. It's really an important topic, but it's been one that I really wanted to do kind of justice to. And that topic is going to be primarily diabetic ketoacidosis, with some discussion, I think, on some of the other types of ketoacidosis.
We're not going to leave out, HHS or alcoholic ketoacidosis.
Right.
Like, there's enough ketosis for everybody.
Yes, there's enough ketosis. I like that. There's enough ketosis for everyone. It's a equal opportunity offender, depending on sort of like what the underlying history is. So yeah, I think without further ado, we can get to a little case and then on with the show.
Sounds good.
All right, so folks, let's say we've got a 42-year-old gentleman, has a history of type 1 diabetes, and they are coming in with a pneumonia. So pretty classic, slam dunk case of a lobar pneumonia, fevers, chills, night sweats, cough, mucopurulence. They got a little bit of an O2 requirement, couple liters, not a big deal. They come into the ER. They get their initial workup. And what is interesting is that they have a blood glucose that's elevated to 485. They have a bicarb of 6. They've got a pH of 7.2. We'll say that's a venous blood gas, but it doesn't really matter. It's low. And they've got an anion gap of 26 with an elevation in their urine ketones. And of course, there's also quite a bit of glucose in the urine. So, Nick, I told you that this person's coming in with a pneumonia. That's kind of a slam dunk. I think one could argue that the other diagnosis that is at play here is also fairly clear, but maybe you could walk me through what you're thinking about here with this patient.
Yeah, so absolutely. So in somebody with a history, particularly of type 1 diabetes, though there are people with like ketosis prone type 2, but particularly type 1, who have a precipitant, we'll talk about the 5 I's in a minute, they can develop DKA. And so I think, before we get into the details of DKA, I'll just start with one really important point, which is that there are 2 ways that people can die from DKA. One is if you screw up managing it, like you let their potassium get too low, you don't address their acidosis, you intubate them, etc. The other is if you don't identify the underlying cause. You could do an amazing job of treating DKA, but if you fail to treat the thing that put them into DKA, they can die from that. So always think about those 2 things. Going back to this case, so the presence of a widened anion gap, 26 is wide. We could talk more about why you should probably look at their albumin too to see what a normal gap is, because this might be super wide if his albumin is low. Another point to make, so you've got ketones, you've got a high glucose, and you've got an anion gap. That's probably DKA. I don't know if you mentioned ketones in the urine. Another test that Another that's great. Another test that we could do would be a blood test for beta hydroxybutyrate, which is, we'll talk about the three different ketone bodies in a minute, but that
Yes.
would be another way to sort of confirm this diagnosis potentially.
Outstanding. Yeah, that's I think a great reaction. So we're leaning towards a diagnosis of, let's say community acquired pneumonia, but also concomitant diabetic ketoacidosis. You've alluded to the eyes, which I think we can get into in a little while. But yeah, this is I think a pretty classic scenario, and one that any intensivist, or really any hospitalist and other kind of allied health professionals, you're going to encounter this all the time. And so I think it's important to understand it. I would say,
So I'll just jump in for a second and say that be careful though. There's a tendency for people to say it's just DKA. And
mhm,
those are some dangerous words, because like I said before, treating it carelessly can be really dangerous. Missing the underlying cause can be dangerous. And importantly, not everything with ketones is DKA.
cosine, hard cosine. So I think, if we want to think about why this is an important discussion in 2026, I think you hit the nail on the head. First and foremost is it is ubiquitous, and yet it is potentially deadly and often poorly managed. So that combination actually scares me quite a bit. I find that very frequently when I admit a patient with DKA, I'm identifying some little issues in management, or lapses in knowledge. And so hopefully this episode will help fill in some of those gaps.
And one other thing I'll say is I want something maybe we'll conclude by talking about is kind of like, where can we improve DKA care in the future? And I think that one of the most important things that's always on my mind when I admit somebody with DKA is sort of like a 5 whys or root cause analysis
Yes.
directed towards like, how can we make sure this is your last admission for DKA? I don't know the specifics of this make-believe case, but a 42-year-old being admitted for DKA who has type 1 diabetes, this is probably not his first DKA admission, I would wager. And so, there's an opportunity here to help him to prevent this from happening again.
Agreed, 100%. So yeah, obviously this is a potentially serious complication of diabetes. It's something that we need to be aware of. We're going to talk about the physiology and the pathophysiology that's relevant here. We also have not really seen, as far as I'm aware, a decrease in admissions for DKA, and with sort of like the prevalence of infections, and then the cost of insulin, people tend to find themselves having to choose between, utilities, a roof over their head, their insulin therapy. A lot of times they're having to take less insulin than they're prescribed, skip doses, so on and so forth. So two of those I's, infection and insulin omission, are, I think, important ones to know. Before I go on, Nick, do you want to just stop burying the lead with me? And what are the other I's that our audience should know about?
Yeah. So whenever I think about the causes of DKA, I always like to sort of think about 5 I's. So the first is infection. The second is ischemia. The third is inflammation. So think things like pancreatitis. The fourth is intoxication. And the fifth is insulin deficiency. And I'm going to sort of direct listeners to the one pager I have on this, but for each of those, I like to think about sort of like, what are the tests or diagnostics that I'm using? So for example, am I going to send like cultures and get a chest x-ray and do a point of care ultrasound exam to look for infection? Might I check a lactate or an EKG to look for ischemia? Might I check a lipase to look for inflammation? For intoxication, I'm going to take a thorough history. I'm going to look for other hints. Maybe I'll do some other testing, like a blood alcohol level. And then finally, with the sort of cross off all of those, we get to insulin deficiency, right? It's very tempting to just sort of blame somebody. Oh, this person is,
Right.
quote, non-adherent, or even worse, non-compliant,
Right.
right? They don't comply. You must comply. But I think, as you've alluded to already, we need to think about why they are perhaps not able to take their insulin. The
Right.
cost of insulin is one. For people who are undomiciled, maybe they don't have access to a refrigerator, so their insulin is going bad. For people who have visual impairments, who maybe they can't measure it accurately, so they need a pen where they can count the clicks. Sometimes it's not insulin's fault, it's something else's fault. So for example, somebody was started on a new med, like a diuretic or a steroid or something else. So sometimes, it is due to insulin, but it's not for the reason that they weren't doing what they're supposed to be doing. So anyway, always think about why, always think about multiple whys, try to get to the root cause. What changed that made this happen? Remember that missing the cause is one of the two ways that people die from DKA in 2026.
All great points. I love that mnemonic. And I'll say, the intoxication one, that can get a little tough. If it's an alcohol intoxication, then of course it introduces the potential for alcoholic ketosis or alcoholic
Mhm.
ketoacidosis. And potentially those folks are maybe not eating so well. So there's an element of starvation ketoacidosis. And then if they happen to be a type 1 diabetic, insulin dependent diabetic, then you could really have three different causes simultaneously for their ketoacidosis. Do you want to react to that, Nick?
Absolutely. Those are great points. So, I mean, I think maybe we can step back and talk a little bit about like, metabolism and why we do things the way we do. So, I mean, you have, glucose is our primary energy source when we're fed, which is, in 2026 for most of us, most of the time true. You have some glucose in your blood. You also have glycogen, which turns into glucose. You have a couple hundred grams of glycogen in your body, which is maybe enough for about 12 to 24 hours. So figure, there's maybe enough glycogen in your body to get you through Ramadan or Yom Kippur, if you're fasting. But historically humans have lacked for food, right? There have been periods of famine, so we have alternative energy sources. The primary way that we store energy in our bodies is fat. So even in a lean person, they might have about 2,000 calories worth of glycogen in their body, about 1 day's worth, but they'll have about 100,000 kilocalories of fat. So way, way, way more, like a month's worth of energy stored in fat. And, this is great. This is a good, abundant energy source. But when you metabolize fatty acids by beta oxidation, you can produce ketones. And that's the sort of price we pay for switching to this secondary energy source.
Excellent. Yes. So, in general, I think that's a great introduction to sort of the metabolism. Carbohydrates tend to be a staple of our diet, especially the modern diet. And those carbohydrates, they get broken down into glucose, right?
I
So
don't know
we
about you, man.
absorb
I
that
have just
glucose.
900 grams of protein a day. I listen
Oof.
to the influencer bros. It's all
That's why
protein. All
that's why you're so yoked. Um, yeah. And you never poop. But yes. So we eat carbohydrates. It's broken down. Get that glucose. That glucose kind of increase in blood glucose in the body is sensed and results in pancreatic beta cells releasing insulin. So that insulin is really important when it comes to sort of cell signaling. So in insulin sensitive tissues, that insulin signaling in particular is going to promote GLUT4 translocation. That's a specific type of receptor, and then cellular glucose uptake thereafter. And ultimately, that glucose, we kind of talked about this before in other episodes, but it's used in glycolysis to form pyruvate, TCA cycles, so on and so forth, but ultimately to produce ATP. And this is really the primary means through which we produce ATP in the most efficient manner. And then kind of when you peel that back a little bit more, we have to consider just how glucose is utilized in different parts of the body. So, of course, in the muscle, it's used as an immediate energy source. You also see glycogen storage there. To your point, Nick, that glycogen storage, that sort of like small but mighty repository for essentially glucose stored in a different form. We see uptake in the adipose where we are able to ultimately produce, fat for storage of energy there. And then, of course, the brain and the liver are using glucose as well. The brain is largely reliant upon glucose to function, which is why we often see folks with DKA or part of the reason I should say why we see folks with DKA start to develop some neurologic symptoms. And then the liver is really probably the biggest player as it relates to that sort of glycogen synthesis, storage, and it's really going to play an important role in sort of regulating metabolism in the fed and unfed states, and in the state of insulin deficiency and insulin surplus. So I'll pause there, Nick, and see anything else you'd add or want to clarify there before we continue.
No, I think it's a great point. So I mean, I'll just add one other point, which is that throughout human history, right, calories have been really precious.
Yeah.
So our body is designed to store every calorie that we don't use. That's why, you get fat production. That's also why normally our kidneys don't pee out any glucose, right? They hang on to it. That's normal
Great point.
physiology.
Great point.
And that's important because 1 gram of glucose is like a couple kcals right there. Like you can't afford to pee out your energy, right? The ancient doctors in India would diagnose diabetes because people would have such high glucose that they would pee out glucose, and then the ants would swarm around their urine, right? This is where diabetes mellitus gets its name. Mellitus is like sweet, like honey, right? Which I guess if you sampled that urine, you might be able to identify in the era
Mm.
before urine dipsticks. But in 2026, the calculus is very different, right? Like now, if anything, we have an overabundance of calories, right, in modern America, and so some of the drugs that we use actually encourage your kidneys to pee out glucose. And maybe one that we should touch on now is the SGLT2 inhibitors, and talk about why they can sort of give you a kind of funny edge case of DKA.
Yeah, let me kind of. I'm going to pop in really quickly, and we were talking about why DKA matters.
Oh yeah.
So why DKA matters? So there's obviously kind of the mortality that we alluded to. Generally, like inpatient mortality in DKA can be up to 1% in a modern kind of ICU. That's 1 in 100 folks. There's kind of a general calculation here that folks that get admitted for DKA, their post admission mortality is up to 13 times that of the general population. And then kind of getting to the point that you just made, about 10% of our DKA episodes are kind of this euglycemic DKA, and that's particularly in the area, and that's particularly in the era of SGLT2 inhibitors. So, Nick, before I go on any further, I've talked about some of the organs that are kind of involved here, some of the key players. We've laid a little bit of the foundation. Anything else from your standpoint? Any other reactions before we get on to talking about some more specific, some more nitty gritty stuff?
So I think, we'll talk about the different ketones in a little bit, because I think there's some important biochemistry there. But before we do, I just want to make sure that we've really painted the full landscape of all of the different ketosis disorders. So
Great.
we're primarily talking about DKA, but it's important to remember that there's this sort of adjacent entity, which changes its name every few years, like any rap star, currently called hyperglycemic hyperosmolar state, or HHS, previously known as honk or whatever. But honestly, that's a better rap name. Um, the, Important to understand the difference between DKA and HHS. So DKA is more likely in type 1 diabetics or ketosis prone type 2. It's more common in young people. It typically has blood sugars in the 400 to 800 range. And these are people who have a ton of ketones and acidosis. Compare this to HHS, which is where people are not quite making ketones yet. They tend to have a much higher sugar, like 800 to 1,000 or 1,200. Tends to be more people with type 2 diabetes. It tends to be older people. And because, as I'm sure we'll talk about, glucose is like the best diuretic ever invented, these people have a larger fluid deficit.
Mhm.
So that's DKA and HHS, but it isn't a clean line, right? There's this whole entity in between, which is this overlap between DKA and HHS. And this is actually the group with the highest mortality. So really important to remember that these people may have a little bit of ketones, some acidosis, but they tend to be harder to manage because they have elements of both, and they tend to have a really big fluid deficit. So you have to be aggressive about replacing that. So important to remember that DKA on one side has HHS. And then on the other side, I like to think about this other entity called euglycemic DKA. So, throughout all of human history, right, calories have been really precious. If you can get glucose out of the environment into your body, you want to hang on to it. So our kidneys are really good at hanging on to it. Unfortunately, in 2026, calories are very abundant, people are larger, and we want to get rid of some of that glucose now. So we invented this class of drugs called SGLT inhibitors. And basically what these do is these trick the kidney into causing glucoseuria. So people will pee out 50 to 80 grams of glucose a day if they're on these drugs. This can cause this weird sort of edge case where people get ketotic. They get the
Mhm.
insulin effects of DKA, but their sugar doesn't rise. So this can fool you. And I think really important to remember that in 2026, a lot of people are on these meds. So this can, if you're looking for hyperglycemia and acidosis to spot DKA, you're going to miss these folks.
That's awesome. And I'm glad, I think throughout this episode, what we're going to try to do is intersperse the physiology with some of the really clinical relevant pearls. And I think that last point, especially on the SGLT2 inhibitors, the potential to cause euglycemic DKA is so important, especially as we're starting to see more folks that have heart disease. And so, like dapagliflozin, for example, is a medication that is indicated for heart failure, certain types of heart failure. There's if I remember correctly, a mortality benefit actually to that particular agent, and it probably is a class effect. So those are becoming fairly ubiquitous, and so as the prevalence of those drugs rises, so does the incidence of euglycemic DKA.
And I think you mentioned earlier that as much as 10% of DKA nowadays is euglycemic DKA.
Yes, yeah, yes. We were talking. I think in between takes here about how that's a issue. Yeah, for sure.
And it's important to remember too that you can see euglycemic DKA in situations other than medication use. So, for example,
Mhm.
in pregnancy. So don't hang your hat on hyperglycemia to define DKA. Think of it more as the presence of ketones.
So, with all that being said, I want to get back. It's kind of like I'm envisioning a wave. So, I want
Yeah.
to take another dive back into some of the physiology, the pathophysiology. So, we've talked about kind of insulin dependent uptake of glucose. We talked about some of the tissues where insulin is, kind of critical. Just to sort of foot stomp the roles of insulin. So, of course, in insulin sensitive tissues, it's kind of this like lock and key mechanism. It opens the door, it opens the lock to the door, allowing insulin to enter. But other important roles include the suppression of gluconeogenesis, the suppression of glycogenolysis, the suppression of lipolysis, and the suppression of ketogenesis, which the last point shouldn't be that shocking because kind of it's, yeah. We're
In
going
the
to get to
presence
more
of
of that. Yeah.
glucose, you have insulin. You don't need to produce ketones. Remember, it's a backup energy source. You don't need to use your backup if you've got your primary working. It's
That's
like
right.
if your house has, a generator, the generator doesn't need to be on when you've got electricity from the street.
Now, finally, kind of to wrap up this section, we've talked about insulin dependent uptake of glucose, but as alluded to, there are several receptors that do not require insulin to sort of open them. And those are like GLUT1, 2, 3, and 4, particularly the GLUT4 in the setting of exercise induced translocation, allows for the entry of glucose into tissues and then subsequent utilization without insulin. So that can occur actually in the brain and in neurons. It's just that process is much more efficient when there is insulin available. And also, of course, kind of with that GLUT4 and exercise element there, skeletal muscle is another place where this can occur. So our bodies are pretty well designed. And evolution kind of has worked well in the sense that we are not wholly dependent upon insulin for glucose intake and utilization, but it makes things go a lot smoother. It's like kind of using your fiber internet versus a dial-up connection to a certain degree.
Yeah, and I think it's important to remember too that, there's degrees of insulin resistance ranging from mild to really severe, and there's degree that's in type 2 diabetes. And there's degrees of insulin deficiency, right? So some people with type 1 make a little bit of insulin. They're not completely deficient. Other people make essentially none and they're completely dependent. And then, there's what used to be just type 1 and type 2 is actually a much more complicated picture with things like mature onset diabetes of the young. You can sometimes see autoimmune type 1 diabetes in older people. Like the world of diabetes has gotten more complicated in recent years. And I think it's really important to remember that, in med school, you learn these sort of clean boxes of type
Right.
1, DKA, type 2, HHS. And the reality is those boxes aren't clean and they're getting less clean every year.
So now that we've really talked a lot about insulin and we've kind of started to unpack ketones, Nick, let's get into the ketones themselves and let's talk about kind of what they are and what they really do. Maybe you can start by telling us, what are the three ketone bodies and why are they really important? Just kind of really break it down for me.
Yeah. So when you break down fatty acids, your goal is to get acetyl-CoA, which can go into the citric acid cycle, and then you can use it as energy, just like you would with, say, glucose. But when you are low on some of the intermediates, you shunt them instead into ketone production. This is kind of like with glucose. When oxygen's around, you run into the TCA cycle, and when oxygen isn't around, you produce lactate. This is sort of analogous.
It is. It's a really great analogy, actually. I love that. I'm going to steal that.
When oxaloacetate is low, you produce ketones. And we don't need to belabor all the steps in between of beta oxidation and all that. But I think the key thing to understand is that, fat is this abundant energy store that even lean people have a lot of comparatively. And so we break it down, right? And we produce in order, first beta hydroxybutyrate. Then that is converted by an enzyme into acetoacetate. And then that is broken down spontaneously into acetone. And each of those is important. So let me walk through them. So beta hydroxybutyrate is usually what we think of as the blood test. This is the lab we order. This can detect ketones in the blood. This is the predominant ketone, usually about 5 to 10 to 1. This is the leading one. So this is the best one to look for. That's why checking beta hydroxybutyrate is the best test we have for it. I'm going to just preempt the angry letter writer and just say, yes, I know technically this isn't a ketone, blah, 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 blah. It is a hydroxy acid, but whatever. It's a ketone body. Okay. That's beta hydroxybutyrate. Beta hydroxybutyrate, in the presence of NAD, gets converted into acetoacetate. Why does this matter? Acetoacetate is what we detect in the urine test. So when you do a urine stick and you see, it turned positive for ketones, what you're seeing is the presence of acetoacetate. So in people who don't have a lot of acetoacetate, people like alcoholics, they can actually have a kind of a faint urine ketone test, even though they've got a ton of ketones in their blood. This is one reason why I prefer beta hydroxybutyrate to the urine dipstick test.
And I'll say really quickly there that like the guidelines and really like expert opinion just kind of strongly agrees with that perspective.
Yeah. I mean, especially since, the urine test sounds great, but not everybody is going to produce urine when you ask them to. Some people are anuric, people with ESRD. So, it's good to have a blood test for ketones.
Yes.
Acetoacetate is just converted spontaneously into acetone. This is what we smell when somebody says, it smells like DKA. You're smelling acetone, right? Like nail polish removal. Sometimes you smell it on their breath because it's a volatile, you can breathe it out. Sometimes you can actually smell it in sweat too. So anyway, if you're using your nose to make diagnosis, that you're detecting acetone, that's probably the least accurate of any of the three. So, if you want to use your nose for diagnosis, that's great, but back it up with a BHB blood test.
Love that. Okay. So again, acetoacetate, beta hydroxybutyrate, acetone, those are the players here. Really, beta hydroxybutyrate is probably the leading, in the lead role, and that's the one we really do need to think about and focus on. We see these ketones utilized in the brain, heart, skeletal muscle, in large part to sort of like keep the body going, keep a patient ticking, even in the setting of an absolute or relative insulin deficiency. And I'll just kind of like briefly summarize, when it comes to the creation of these ketones, I think you did a great job, Nick, of touching on some of the highlights, but essentially we see that insulin deficiency, again, whether it's absolute or relative, results in hormone sensitive lipase activity that is kind of upregulated. We see breakdown of triglycerides into free fatty acids, that beta oxidation that you mentioned, increase in acetyl-CoA, and then ultimately we produce so much acetyl-CoA in that setting that you're like, again, analogous to the oxygen situation, hypoxemia and lactic production, you basically have so much acetyl-CoA that it's not able to totally be utilized through the TCA cycle, and you're kind of diverted into ketogenesis, and that's where the problem sort of can arise. The one point I want to make here that's kind of like orthogonal to the discussion is I talked about hormone-sensitive lipase here. So hormone-sensitive lipase found in adipose tissue is important because that's really what's going to be triggered by the insulin deficiency and trigger the subsequent steps that I mentioned. We don't want to confuse this with lipoprotein lipase, which
Heavens
clears.
no.
Right. Which they, I've done this before. I made that mistake, but the thing is, they're very different. So, like, lipoprotein lipase is actually activated by insulin. And we use that mechanism. We take advantage of that mechanism in the setting of one kind of classic pathology, which is pancreatitis secondary to
Yep,
hypertriglyceridemia. So we
exactly.
utilize that mechanism to try to clear triglycerides. So two different enzymes here. There's lipoprotein lipase, which is not really playing a role here in ketogenesis, but rather it's hormone sensitive lipase that is the player here that we need to know about.
Good points.
Let's be honest, ECMO programs thrive or die by two things: how well your team is trained and whether you have enough clinicians with the skills and expertise to confidently manage these high acuity patients.
Integration Health gets it. Integration Health provides comprehensive ECMO education to more than 1,000 providers every year. From high-fidelity simulation done at your facility to online CME courses, so teams can stay sharp even when case volume is low or when there's a long gap between ECMO runs.
Staffing gaps also derail ECMO programs. When you're short-staffed or dealing with a busy CVOR, Integration Health will deploy experienced ECMO specialists to your facility within 24 hours to keep your program running without compromising care.
From keeping your team trained up or providing staff to cover staffing gaps, Integration Health has your team's back. Learn more at integration.health. That's integration.health.
And now back to our show. So, I think we've talked a lot about the ketones here. I think it might be a good idea then to just summarize the pathologic ketosis that's happening in DKA. And I think, really what I would say is, and Nick, you can certainly chime in here too, is you've got two big elements here. There's this severe insulin deficiency. It's going to result in unrestrained lipolysis. It's going to result in massive ketone production and a progressive acidemia that obviously can be very problematic.
That's bad.
That's bad news. And then you have these counter-regulatory hormones that essentially are amplifying the process. You've got glucagon, catecholamines, cortisol, growth hormone, all these other elements that are sort of like adding little bits of kerosene to the fire. And if left unchecked, if left untreated, this becomes a fatal condition.
Exactly. The way I think about this, and maybe this is sort of a segue into treatment, is there's sort of three big problems we have to fix when we're confronted with DKA or HHS for that matter. The first is this insulin deficiency, which is causing ketosis and acidosis. That's bad. So we need to give insulin for that. The second is having had a high glucose for a while is a really profoundly good diuretic. So these people are all volume depleted. So we have to fix that. We also have to fix the hyperosmolality that goes along with ketones and glucose. And then finally, all of this acidosis is deranging electrolytes, right? So you're shifting potassium, you're also peeing out potassium. So we have to correct electrolyte deficiencies. And so I think of those as sort of the three pillars, the things that we have to fix, the things we have to monitor, as we're doing this. Fix the insulin, fix the electrolytes, fix the volume status.
All right, so now that we've talked a lot about ketones and a lot of biochemistry, let's get back to the focus here, which is sort of the clinical aspects of the presentation. So, Nick, maybe you can walk me through what are some of the typical signs and symptoms you might see in a patient who you suspect has, ketoacidosis or specifically DKA?
So I think a couple of things. Maybe the most obvious is going to be from the doorway. They're usually going to be not just tachypneic, not just breathing fast, but also breathing deep or hyperpnic, if you want a word for that. Sometimes people refer to this as Kussmaul respirations. This is where somebody's breathing very fast and very deep together, maybe like 30 plus times a minute and taking like full tidal volume breaths. Why are they doing this? Well, they've got this rip-roaring metabolic acidosis, so they're blowing off CO2 to compensate. Sometimes I think people can make this mistake of they look at somebody and they see that their CO2 is low and they think that's the problem. No, that's their attempt at a solution. And
Yes.
in fact, the single most dangerous thing that can happen to these folks in the ICU is that they develop respiratory failure and their CO2 starts to climb and now their acidosis gets way worse. So there's nothing scarier than a normal CO2 in somebody with severe DKA and acidosis.
And Nick, you had mentioned kind of early in the episode, you'd alluded to intubation, the perils of intubating. I think that this dovetails nicely with the point you just made. Do you want to unpack that a little bit before we go on?
Yeah, so I'll just I'll tell our listeners that there's a longer discussion of this in our physiologically difficult airway episode. So direct you there for the long version. But to give you the short version, the danger whenever you intubate somebody is a couple of fold. Number one, they're going to be aptic for a little while. And so if they were breathing very, very fast in order to maintain a low normal or maybe even low pH, if you make them breathe not at all, even for, let's say, 30 seconds or a minute, that can cause their pH to plummet. So somebody who's intubated starting off with a pH of like 7 or less is an extreme danger. That 60 seconds of apnea could be fatal. So these are folks that I'm going to use something like non-invasive ventilation to hyperventilate them, to give myself a little reserve and to maintain ventilation until the second I'm ready to put the tube in. So I think that's a really important point to understand about these folks. The other point is that great, you got the tube in, but can you ventilate them adequately? Sometimes you can't. So this is another thing to consider, which is that negative pressure breathing is more efficient than positive pressure breathing. So you're able to ventilate more breathing on your own than you are breathing on a machine. So whenever possible, it's better to fix the problem and let them breathe on their own than to put them on a ventilator, which usually taps out at about 30 to 35 liters a minute ventilation. Whereas,
And that's huffing it too. That's pretty good for a vent.
that's about the best you can do in most of the time. Whereas, if you spend time in the PFT lab, what's a normal maximum voluntary ventilation? Could be over 100 liters in somebody healthy. So I
Yes.
mean, somebody who's working really hard to breathe can breathe really efficiently. And they can blow off a lot of CO2 and maintain a normalish pH. So be very, very wary when somebody with DKAs and respiratory failure, like in the patient you started this episode with, actually, the person with pneumonia with DKA is much more dangerous than either DKA or pneumonia alone. The synergy is very risky. So other physical exam findings, maybe less overt than the fact that they're breathing like a racehorse, probably going to appear hypovolemic, right? So this could be things like their skin looks sallow, they have low, they're not sweating much, they have low skin turgor, things like that might be clues. Ironically, they're probably peeing a lot though. So, this is somebody who's dehydrating themselves even more. This is because, remember, glucose is a great diuretic. So it may seem a little paradoxical there. Other manifestations?
Yeah. So, I mean, I think, we've covered a lot of them. I think the big one that I'll just mention is you want to look for altered mental status,
Mm,
because that's going to be, that's oftentimes one of the major indicators to like the severity of the DKA. And so that's, that's the situation where it can be really hairy, where you might have to take the airway for airway protection. But
yep.
you did an elegant job there, Nick, of really explaining why we really don't want to do that, because it is virtually impossible to keep up with the minute ventilation if you place an endotracheal tube. But it's also pretty much impossible to keep up your minute ventilation if you're completely obtunded.
Exactly. So rock in a hard place. The best thing to do if you find yourself in that situation is to plan ahead, call for help, and do it in a as much of a thoughtful, controlled manner as you can.
Yes. So, kind of shotgunning through these, just to give our listeners a list. From a symptom standpoint, we think about polyuria, polydipsia, weakness, weight loss that can occur over a period of times leading into the DKA, nausea, vomiting, of course, and some belly pain as well. I'll mention too that belly pain could be seen not just in the setting of DKA in and of itself, but also if that person has like pancreatitis or something like that. That belly pain could be then both a symptom, but it could also tip your hat to a precipitating factor. So it's complicated.
Absolutely. And sometimes it's really hard to know is somebody's worst headache of their life due to just the fact that this is like the worst they've ever felt because they're in DKA, or is it there's some underlying thing that put them into DKA? Likewise, somebody could have back pain, there's just a lot of symptoms. So I think that the important thing is to be thorough, consider the 5 eyes, look for those causes, do that with labs, do that with imaging if necessary, do that with your physical exam, certainly.
Perfect. Okay. So I think that's a pretty good, a very good foundation for sort of like the physiology, the pathophysiology, what to look for, what should really like make your spidey sense tingle, so to speak, as far as like a DKA type patient. I think we need to get into diagnostic criteria, but just one kind of brief aside here is we've talked a lot about the acid-base disturbance or acid-based disturbances in the setting of DKA, or alluded to some of them, talked about some of them, but just to sort of like flesh that out a little bit, the primary disorder is a high anion gap metabolic acidosis secondary to those ketone bodies, that ketoacidosis. It is often seen in conjunction with a second hagma, because you'll often see a lactic acidosis in these folks. So don't be surprised if that's the case. That lactic acidosis is the kind of the one case that I see fairly commonly where the lactic acidosis can resolve pretty nicely with volume resuscitation, because again, these folks do often come in dehydrated secondary to that glucosuria, that osmotic diuresis.
Quick plug too that on our website with this episode, we've got a calculator that I built for acid base that can kind of
Yes.
help you with this NAGMA, HAGMA identification.
And so there you've alluded to the fact that like there's also a potential NAGMA that you can see. So oftentimes during recovery, you'll see this either because the person's gotten a lot of NS, so you get that chloride, hyperchloremic sort of non-gap acidosis, or they've lost a lot of bicarb equivalents in the setting of this diuresis. So that's one other thing to consider. On top of this, you can finally see, well, maybe not finally, but another common finding would be nausea, vomiting. Vomiting, of course, can sort of cause a metabolic alkalosis as you're throwing up those gastric acids.
Yeah, the hint there is often a hypochloremia too. So yeah,
Yes.
I think you make a really good point, which is that DKA is often a little messy, right? It's often
Yes.
not just one metabolic derangement, but many, and they can resolve with slightly different timescales too. So I think this is a great segue into this idea of like what are we monitoring and how often, right?
Yeah,
Like
absolutely.
so like you get the call from the emergency department and they're like, oh, this person's got we think it's DKA. And then the question is like, okay, great. Now what?
Yeah, so that's right. So okay, now what? So I think that leads us, we're going to get into sort of like the treatment algorithm, so to speak. But before that, you want to have tools to make the diagnosis. And so I think, there's sort of some specific things that we want to look for. And I can kind of run through those
Go for
quickly.
it.
And then Nick, you can tell me a little bit about severity. So when it comes to just making the diagnosis, in general, we're talking about an elevated blood glucose. So, kind of above 200 with a history of diabetes, that's one of the boxes to be checked. Recognizing that while we often think about a sugar of 350, 450, something like that, those euglycemic DKA folks can sort of throw you a curveball. So, be on the lookout for that. You also are going to have ketosis, right? So, that's best to determine through beta hydroxybutyrate, that serum test. And really, a beta hydroxybutyrate level that's greater than 3 millimoles per liter is what's going to really kind of clinch that diagnosis, although there are certain shades of gray there. And then the final one I'll mention is kind of the acidosis, or really the acidemia. So what we expect to see is really a pH that's less than 7.3 and or a serum bicarbonate that is less than 18. So with that being said, Nick, do you maybe want to tell me a little bit about severity?
Sometimes people use sort of anion gap as a shortcut here. I would just caution you that like there's a lot of things that can give you an increased anion gap. So don't jump to the conclusion that high glucose plus high anion gap must be DKA. There are many other things on that list to consider.
So, Nick, we've talked a little bit about the diagnostic framework now, and I'd asked you before if maybe with that sort of framework in place, how do we then get granular? How do we define severity so that we know who could maybe do okay in a step down progressive care environment versus who definitively needs to be in the ICU?
Yeah, so exactly. So basically using the sort of labs that we've already alluded to, so the beta hydroxybutyrate level, the pH, the bicarb, and then sort of an assessment of their mental status are sort of the key parameters. So mild DKA is usually defined as a beta hydroxy less than less than 6, a pH, which is kind of low normalish, so maybe like above 7.25, over 7.3, a bicarb, which is low normalish, maybe like 15 to 18, and somebody who is alert. Moderate will be worse than that, so like a pH, which is like 7 to 7.25, so pretty low. A bicarb, which is like 10 to 15, so pretty low, and maybe a mental status which isn't fully alert. And then I think of severe as a very high beta hydroxybutyrate, like greater than 6, a very low pH, like less than 7, or a bicarb less than 10, particularly in somebody who's stuporous or comatose. Who needs to go to the ICU? Definitely that last group, maybe that middle group, and then depending on your institution, probably not that first group if you can handle it. And I think maybe one thing we can talk about at the end of this episode is, where is DKA management going, and how can we avoid, quote, using up an ICU bed on DKA in the future? Because I think not everybody with DKA needs to be in the ICU, but the question is, can we risk stratify them safely and treat them as well outside the unit?
Perfect. Well said, Nick. So, obviously, you alluded to some of the laboratory values, and we've talked about those before. But I would say, just to again give our listeners a kind of quick soundbite in terms of what we need to be checking if you're admitting a DKA patient or a patient with high suspicion for DKA. I think a CBC is helpful. You want to make sure that you at least have a baseline. Make sure you're not missing some sort of, like, I don't know, unexpected anemia, massive leukocytosis, something along those lines. You're obviously going to need a CMP or a BMP to get some of those initial values we've discussed, the bicarbonate, for example. We're going to need a blood gas to sort of determine, is this an acidemia or is this an acidosis, and kind of give yourself a baseline. The serum beta hydroxybutyrate,
Let me jump in there
super
and say that
helpful.
a VBG is often all you need here.
Yes.
That you don't really need to be poking somebody for arterial blood. Peripheral VBG is fine.
This is actually probably one of the best use cases for that, because the common patient that comes in is going to be like, satting 100% on Roumare or something. Like, we're not really concerned about hypoxemia in many cases. And even if we are, we have other tools. But yes, your point is well taken.
That said, though, often in these folks who are needing very frequent blood draws, having an arterial line for blood draws is actually a good move, especially because it's a closed circuit, you only draw a little bit of blood. So instead of like wasting 10 cc's with every lab draw every hour, right, which adds up quick, sometimes if they're sick enough to need an art line, it can actually make their care much more expeditious and reduce a lot of waste.
Other things that I would get in addition to what we've already mentioned, of course, that beta hydroxybutyrate, which is a nice sort of like a baseline study, would be an EKG, urinalysis. That's going to help you identify ketonuria to the extent that that's helpful. It'll help you identify glucoseuria, again, to the extent that that's helpful. Pregnancy test, I think, is super important, really in any lady of childbearing age. And then who still has a uterus. And then I would say other things to think about would be like blood cultures, chest x-ray, troponin, Nick, to your eye, ischemia, getting a troponin in the appropriate patient, I think, is useful. And then a lipase, because a lot of times we'll see pancreatitis in the setting of DKA.
And I'll just throw out there that I like procalcitonin a lot in these folks.
Yeah.
I'm sure we can have a controversy episode of that later.
That's very naughty, but yes, I agree.
A couple other points to add to that. You mentioned electrolytes. We should probably be specific with folks that you actually do care about a magnesium here, because somebody with low mag will continue to waste potassium.
Yes.
So that's one important differential you need to check off. Check a calcium too, because that can be abnormal, and then check a phosphate. Usually phosphate is kind of this neglected electrolyte, and in this case it can be really severe. Recall that you're going to be shifting phos intracellularly, so your extracellular phos can get quite low, and that can, if it's extremely low, like less than 1 millimole per liter, that can cause big problems. So you want to be checking that initially and then somewhat regularly thereafter.
Yeah, those are great points. Those all important ROM key or ROM-K channels, excuse me, are sort of the ones that are implemented or implicated in that magnesium-dependent potassium absorption. Fun little factoid of probably a little clinical relevance. But more important is the fact that when we treat DKA, and we're going to get into the treatment here very shortly, you can kind of kick off what is essentially a refeeding syndrome And that is in large
Yep.
part why you see this FOS kind of drop pretty precipitously in some cases. And so your point is incredibly important. Like you have to be vigilantly watching that FOS, that potassium, so on and so forth. So I think with all that being said, I think it's a good as time as any to talk treatment, and maybe we can start with kind of like initial assessment and talk fluids. Do you want to try to do that, Nick?
Yeah, absolutely. So when I think about treating DKA, I think about sort of three pillars and three phases. The three pillars are insulin to correct the ketosis acidosis, electrolytes to correct the deficiencies, and fluid to correct hypovolemia. And the three phases are sort of an initial phase, which should begin in the emergency department, an intermediate phase, which consists of sort of gradually and carefully correcting these things, and then a resolution phase, where you're going to transition from sort of like more invasive things like IV insulin to sub-Q insulin, and transition to like, here's a meal you can eat instead of maybe giving you glucose,
And I want to make
and
one really quick point, because you
yeah.
said this very intentionally. The insulin is not there to treat the hyperglycemia. Yes,
Mm,
it does that. Of course, it's going to do that. But the hyperglycemia here is really like the tip of the iceberg. It is the ketosis. It's allowing us to metabolize those ketones and get rid of them. That's why the insulin is so important. And I know that that's often forgotten or
that's exactly
misunderstood.
right. Right. So there's this sort of phenomenon of euboxia where people want to make the red boxes in the EHR turn black. And,
Yes.
the glucose is a very conspicuously red box. There's maybe some exclamation points after it. You want to make that turn black. Nah, the box you want to fix is really the pH. And the way you're going to fix the pH is by treating the acidosis and ketosis, right? And the way you're going to treat those is with insulin, just like you said. I think it's important to dwell on this point because once somebody's glucose has normalized, as in it's like less than 200, so not that normal, but like normal-ish, if their gap is still open, if they still have a ketosis, you actually have to give them glucose so you can keep giving them insulin, right? This is an important point. Another important point that you alluded to is, this is a gradual process. We have to get your cells to stop producing ketones. This is not like, oh, here's a bunch of insulin and they'll do it. They have to be treated with insulin, sort of bathed in insulin for a while for that ketosis process to stop. And there's a real danger if you give too much insulin too quickly that you can cause hypoglycemia, which can be very dangerous in these folks. You're also shifting glucose really fast, so you can get a lot of osmotic derangements as well, which are bad.
Excellent. So you mentioned those pillars, Nick. And so, in the spirit of kind of touching on these sequentially or logically, I was thinking maybe we could start by talking about fluids.
Yeah.
Quickly, before we jump into that initial assessment, this isn't really going to vary much from like other conditions. ABCs, vitals, mental status assessment. Make sure you have an eye on their hemodynamics. We talked about precipitating causes, and we talked even about, I think, point of care ultrasound and potentially using that to help you elucidate that precipitating cause. I think all of that is germane to pretty much any patient you're going to admit to the ICU, and it doesn't change in the world of DKA.
Yeah, I think one thing that is important though is, the goal is to fix hypovolemia without overdoing it. Right.
Yes.
So frequently I will use some sort of test of fluid responsiveness in these folks. I like NICOM because it's a nursing directed protocol. Now, obviously, when you meet somebody with DKA, they're going to be hypovolemic, right?
Right.
They're liters and liters down. Check one at baseline and then check one with each liter that you give so you can find out when they're no longer volume responsive, right?
Yes.
Because these folks are going to need a combination of boluses. And this is actually one of the rare situations where I use maintenance fluids.
Yes. Yes. But Nick, what about the heart rate? Can't you just follow the heart rate? It's going to go down, right? I mean, when they're getting
I mean,
resuscitated.
their heart rate's going to be janky for a lot of reasons. This
Yes.
person that your case, they've got a pneumonia, they're acidemic. There's a lot of other things that are probably contributing to the high heart rate. I mean, remember, if you're breathing 30, 40 times a minute, you need to be delivering CO2 to your lungs at an increased rate as well. And so your heart rate has to be high. That's normal, right? You wouldn't expect your heart rate to resolve until all of these derangements have resolved. So bolusing until somebody's not tachycardic is gonna probably overdo it.
And you didn't fall in my trap. So very good. Okay. So getting to fluids. So we've sort of alluded to this a little bit and how NS can cause problems. Nick, what is your fluid of choice? Why? And how do you approach fluid resuscitation in the DKA patient?
Yeah, so there's been, this controversy over the last many years about balanced crystalloids versus like conventional crystalloids. This is deserving of its own episode. I can get into the history of lactated ringers, or ringers lactate rather, and and normal saline and why it's not normal. That's a conversation for another time. What I would say right now is that the evidence we have is that the people who benefit the most from balanced crystalloids are people who are getting a lot of crystalloids. And those are people like this. Those are people who are going to get 5 or 6 or 8 or 10 liters of crystalloid, right? And so this is probably the time that it matters the most to use a balanced crystalloid. So if money is no option, Plasmolite 148 is great. If you work in most hospitals, lactated ringers is a great option.
Mhm.
I think, I don't like normal saline in these folks because you're giving them an enormous amount of chloride. 5 liters of NS is a ton of chloride. It's also hypertonic, and there's a lot of problems with it. So LR is my choice. Now, there's some subtlety though. Sometimes people will say like, wait, their potassium's low. Why don't you put them on LR plus maybe 40 of K, 40 milliequivalents of K? Because then you can fix potassium faster, right? Well, the problem is that most hospitals have rules about how fast you can infuse potassium, typically no more than 10 milliequivalents per hour. So if you do that, you're kind of limiting how fast you can bolus them with that LR. So I usually try to keep these separate. I'll do
Yep.
electrolytes and I'll do fluids. I don't try to be fancy and mix and match. The other point of subtlety with fluids is we mentioned this before, but like at some point, their glucose is normal, but maybe they are still producing ketones. So at some point, you're going to have to switch from crystalloid to a crystalloid that contains glucose. And so you switch from LR to D5 LR.
Excellent. I love that. And yeah, I think that was yeah, wonderful coverage of the fluids. I think the one thing I would add is kind of like this idea of some special populations as it relates to fluids. And
Yeah, good
so in
point.
my mind, that would be like your older adults, folks that are pregnant, folks with heart failure, folks with ESRD. And so I often think, in these folks, it's even more challenging. Things that I'll do is I'll still use boluses, but smaller boluses. I'm going to be really anal about my frequent reassessments, POCUS, NICOM, what have you, paying attention to their volume tolerance. And then, this is getting to something we're going to talk about in a little bit, but if someone's sort of on the fence as to like, am I going to treat them kind of in the traditional way, or maybe am I going to go in a different direction? I might be more inclined to go in a different direction with their DKA journey and kind of use that subcutaneous insulin regimen to try to maybe reduce a little bit of the volume, approach
Good point.
there in conjunction with the smaller boluses, something along those lines. So that was the one thing I was going to add. I think your point on the dextrose containing fluids is incredibly important as we sort of transition that patient's care.
All right, quick sidebar. We all know that airways in the ICU are just a little different.
Yeah, different's one way to say it. Nothing's optimized. The physiology's completely deranged, to say the least.
Yeah, difficult might be another way to say it. And that's why we were excited to share the Difficult Airway course, Critical Care, a course that's built for the reality of critically ill airways.
It's practical, hands-on, and focused on the stuff that actually shows up at 3 a.m. Whether that be soiled airways, surgical airways, or what have you, when things start going sideways, you'll be ready.
Basically fewer, I hope this works moments, and more, I've trained for this moments.
Absolutely, and the faculty cannot be beat, folks. You've got airway experts from all over the world with one focus, making you more confident managing those nightmarish airways.
Upcoming dates are Boston, May 1st through 3rd, 2026, and San Diego, November 13th through 15th, also 2026.
And just like last time, Critical Care Time listeners are going to get a little bit of a bonus if you use the code CCTIME26, so CCTime26, you'll save $200 on tuition.
Nice. Get all the details and register at www.theairwaysite.com. Just search for the Difficult Airway course, Critical Care. You'll find all the stuff you need.
And now back to our show.
One other point about fluids, actually two other points. One point is that in some people, the best fluid is bicarb. So in people with a
Yeah.
really severe acidosis, sometimes that is a good move. You just
Mhm.
have to do it if their pH is like persistently less than like 6.9. They probably need acutely raising it.
Yes.
Now, we've talked about this before, but in order to raise your pH, bicarb has to turn into carbon dioxide. You have to breathe that out. So if you're ventilatory limited already, bicarb may not raise your pH very much. It's kind of like when you drop Alka-Seltzer into water, the pH of the water is going to increase because CO2 is bubbling out, right? If you think about a person that's like an Alka-Seltzer, you're dropping Alka-Seltzer into a person. If they can't blow off that extra CO2, their pH won't increase either. So sometimes you get less bang for your buck here. One final point I'll make is, occasionally you meet somebody who has like ESRD who's anuric. And so this is the exception. This is the DKA who isn't hypovolemic because they can't pee out all this fluid. They might have insensible losses. They're breathing fast. They're losing some fluid that way. They might be sweating. They're losing some fluid that way. But this is not the person who's got an 8-liter fluid deficit. So be sure to assess your actual patient and don't just reflexively give, 2 liters up front and then 250 an hour just because it's in the order set.
Awesome.
So that's sort of one pillar. That's the IV fluid correction of hypovolemia pillar. On to the next pillar. Cyrus, do you want to tell us about insulin? How much, how do you give it, et cetera?
Yes. So I'm going to try to make this as simple and straightforward as possible. Again, there's this core principle of the insulin is not really for the hyperglycemia; it's for the clearing of the ketoacidosis. So keep that in mind. That's why Nick told us that we need to make sure we have a dextrose-containing fluid on hand to transition to during treatment with insulin. And so there's a couple of different things to think about with insulin. I mentioned that in some folks, especially those with mild DKA, volume considerations, maybe folks who you're trying to not necessarily admit to the ICU, you could do a subcutaneous sort of sliding scale correctional type approach with Q1, Q2 hour glucose checks and really use that to manage your ketosis and sort of quote unquote manage the blood sugar. And that's going to be really in that subset of patients where their disease is more mild, and you anticipate more of a swift resolution of their DKA. What we're going to focus on now is really the folks that are going to be on an insulin infusion, and so the goal here is to start that insulin infusion as soon as possible after the diagnosis is made. Unless the patient has a potassium that's less than 3.5. Some literature will say 3.3, but I like 3.5 because it gives you more of a buffer. In terms of dosing that insulin, really there's this bit of a controversy in terms of like to bolus or not bolus. I don't think that a bolus is really that helpful, with one caveat. I do like to bolus the patient long-acting insulin. There was some equipoise here over the last few years, but in the most recent kind of literature search I did, there's a 2026 meta-analysis that looked at this, 2025 meta-analysis that looked at this, so significant patients, hundreds and hundreds of patients. There is evidence to support use of like glargine is the one that I typically use, kind of within the first 6 hours or so of admission, evidence to support it reducing time to resolution, time in the ICU, without really significant risk factors. So if I'm bolusing anything, I'm going to bolus glargine, and I'm often going to base that off of their home use or maybe a weight-based dose. And I'm going to do that in concert with a insulin infusion, which I typically start at 0.1 units per kilogram of the patient's body weight, up to a maximum of about 10 typically. With that being said, Nick, what do you think?
I think this is one of these things which has changed a little bit. So it used to be the traditional thinking was, don't give them sub-Q, they need to be on IV. And it always struck me as a little bit weird because it's like they got into this mess because they weren't taking sub-Q insulin in many cases. So now
Right.
we're not going to give them sub-Q insulin. Like, why not do both? And so I think a lot of the literature is leaning in that direction. I think one really important thing to remember is that, your goal is to achieve a gradual reduction. Sometimes I think this is something that ICU nurses really understand because they have to do it, and doctors seldom understand because they don't have to do it. But like the titration of the insulin drip has to be done carefully. And the goal is to drop the blood glucose at a controlled rate. You don't want it to not drop. You're not giving enough, and you don't want it to drop too fast. And so there's a lot of fine tuning there. And that's the good thing about IV insulin. You can fine tune it. If you just give a bunch of sub-Q insulin, you're going to find out over the next 12 hours whether you gave the right dose or not.
That's right.
Arguably somebody who is in shock may have different absorption. So your sub-Q meds may have, different kinetics. So it's that I think it's a good argument for why people who are really sick need IV. But I think there's this growing question of, who are the people who don't need IV? And that maybe we can close by talking about that.
Yeah. So, okay. Getting back to those people that are on the insulin infusion. So typically once the glucose falls below 250 or so, that's when we're going to add that dextrose containing fluid. And we're also simultaneously going to reduce the insulin infusion to about 0.05 units per kilogram per hour, as opposed to that 0.1 units per kilogram per hour. Although that's going to vary to a certain degree based upon where the patient is at, what kind of dosing they're currently getting. So it's hard to really prescribe that. I often end up kind of having whatever they're currently getting. And then again, you're continuing to check, you're continuing to make adjustments and continuing the therapy until their acidosis resolves.
I also like to look at what was their home dose if they were on insulin, because it's probably not wildly different than that number. The other thing I like to do is, like, typically when you go to the point of converting to sub-Q, you've had a couple hours of steady state on IV. And so you can kind of say like, oh, they were getting, 1.5 units an hour for the last couple of hours. That means that in 24 hours, they would get about this much. Let me have that to be safe, and we'll see what happens.
So let me, and I want to clarify for our audience a couple points. So the sort of dropping to 0.05 units per kg per hour is that sort of like transitional step to the transition. That's like, that's what we're going to do while they're still on the drip. And then eventually they're going to have to go to sort of a basal bolus strategy. And that basal bolus strategy, if it's someone who you like really are trying to figure out what to do, you don't have any baseline, 0.1 or maybe like 0.2 to 0.3 units per kilogram is a reasonable sort of like daily dose of insulin to start someone on. And then you can sort of like divvy that up into 50% basal, 50% sort of TID AC. So that's one way to do it.
Good point.
Nick, to your point, you mentioned like using the insulin drip, you can sort of use that in the last few hours to extrapolate what that patient may benefit from. It's really important, and I cannot stress this enough, to focus on the sort of tail end of their treatment. Why do I say that? Because the tail end of their treatment is going to be much more reflective of like who they are when they're walkie-talkie normal than what are their insulin requirements like when they're in the throes of DKA. If you dose them based on like the last 24 hours and 16 of those hours were when they were like really, really sick, you're going to way overdo it. So I think if you're going to use that strategy of like seeing what they've been using on the drip, just confine it maybe to the last no more than 6 hours and then extrapolate from there.
Yeah, absolutely. Once they're at kind of steady state, I think that's the key thing. Yeah.
Huge point.
All right. Excellent. So that's like 2 of 3 pillars.
It is.
Do you want to talk to us about the third pillar, normalizing electrolytes? Like, what are our concerns and what are we doing?
Yes. So electrolytes. I think that's an important pillar. It's all of them are important, but that's kind of the third one that we haven't really touched on. The pillar, I guess, could be divided into some other sub pillars, if you will, and perhaps the most important one to think about is potassium. When we think about potassium, really, like, a lot of times your total body potassium is depleted in DKA, even if that initial serum potassium is normal or high. That has to do with sort of the shifting of potassium and how, once you start insulin, correcting that acidosis and giving insulin is going to drive potassium intracellularly. And so a potassium that's like borderline low but still normal can very quickly become real deal hypokalemia. So what I typically say is, if someone's got a potassium of 5+, you can probably just start treating them. If someone's in the neighborhood of 3.5 to 5, I would start giving them potassium in the way, Nick, that you had described. I like to keep it separate. I like to be able to fine tune things. And then if someone's potassium is less than 3.5, I would hold their insulin. I would replete the potassium first, because that hypokalemia can be really, really problematic. And it's very kind of like a high stakes part of DKA management. And then once we're kind of above 3.5, 3.7, something like that, then I'll go ahead and start treating. That's my take on it.
And no, exactly. And I think one important thing that we sometimes overlook is that we're giving people IV potassium replacement, but not PO. If somebody can swallow PO, that's a much more efficient way to give it to them, because you can give them 40 milliequivalents. Here, swallow this, as
Yes.
opposed to here's 40 milliequivalents infused over 4 hours. So
Great point. It's sometimes what I've had to do, like I had to do this recently, is I'll give someone, if someone eyeballs well, mental status is not a problem, they're a little bit nauseous, I might try to give them a little bit of Zofran to see if I can give them some of that oral potassium. And that can work well. I wouldn't say that should be like your rule for managing the hypokalemia, but that's another trick that you can use to sort of get a little more potassium in the patient.
yeah, prudent not to give somebody who's vomiting a giant horse pill of
Yes.
potassium. Yeah.
Absolutely. The other things to talk about kind of on the on the BMP, M is in Mark.
Metabolic.
Metabolic, sure. I like Mark, I'm talking to Mark. So anyway, we've sort of talked about FOS and the importance of keeping an eye on your FOS up front, repleting it as you're treating. We've talked about magnesium and that relationship. The bicarbonate thing, I want to hammer that point home as well. So someone with a serum bicarbonate that's in the sub 7 category, they often are going to need an amp or like a push of bicarbonate just to sort of get things moving in the right direction. Short of that, the time when I use bicarbonate most often is kind of what we were alluding to before, which is that like you've treated them, they've met their sort of endpoints of resuscitation, which we think of as being like, beta hydroxybutyrate's less than 0.6, pH is looking good, bicarb's greater than 18, glucose is, less than 200. They've checked those boxes. Well, with the exception of the bicarb. Like, let's say the bicarb is still hanging out at around 16 as opposed to that greater than 18. That's very possibly going to be your non-GAP acidosis or acidemia. And those folks often do well with a liter of isotonic bicarbonate.
Yeah, I think of it like if you can count their bicarb on one hand, they probably, you probably need to give them some, even though the evidence for this is admittedly pretty weak. The evidence that bicarb improves outcomes in any setting is not really. It's kind of like study not found. But I think it's reasonable physiologic interpretation to say that when somebody has got shock from acidosis, fixing their acidosis with the help of bicarb may be a reasonable strategy.
That's wonderful. That's I think a wonderful little pearl is that, like, if their bicarb is fewer than the number of fingers you have, then probably.
I mean, assuming a normal number of fingers, yes.
Fair point. Now, I think as we sort of get towards the end here, Nick, I know that you have some important pearls that you wanted to discuss in terms of like, sub-Q insulin and maybe some other factors that folks should consider when they're treating these folks. I have some sort of bottom line teaching pearls. The one thing I wanted to get off though, here before I turn it over to you and then we close out is what does right look like when you're managing DKA? So we've talked about the endpoints. We've talked about the plasma ketones, the beta hydroxybutyrate, checking that and kind of making sure that's resolved. pH greater than 7.3, bicarb greater than 18, and ideally a glucose that's less than 200. The anion gap, which a lot of people look at, is not the be all and end all here because a lot of things can confound that. We've talked about that. Ketonuria or glucosuria, those are also not really things that I necessarily look at for endpoints because they can be confounded as well. For me, what I look at or what right looks like is you get the person on that initial phase of therapy. They're on the insulin infusion. We're giving them fluids, as we've discussed, all of those things, and we're giving them early long-acting insulin. Once that patient is ready to eat, once they feel like they have a diet and all of those endpoints of resuscitation have been dealt with, I will keep everything going, get them a tray, and see if they throw up or get nauseous right away when they see that food. If they do, that tray goes away and we're still in a holding pattern. If they look great, then what I'm going to do is I'm going to stop everything I'm doing. The one thing I see a lot of the time is the sugar water continues. And you're like, why? What's going on here? It's because they're still getting that dextrose containing fluid at like 200 cc's an hour and it didn't get turned off. So you got to stop all that stuff. There's no need to overlap in this scenario because you've already given them that long-acting insulin. And then you're going to give them their Mealtime aspart, whatever you've determined is appropriate,
Short acting.
give them their food. Short acting, right?
Yeah.
You want to cover them because remember, like this is another area where people mess up. Yes, their blood sugar has been normalized-ish. Time now. You're about to give them a bolus of glucose. You're about to give them food. You need to cover that. So you're going to cover that with the mealtime insulin, with the short-acting insulin. And generally, you're going to check a blood sugar then, but generally they're not also going to need correctional on top of that. You're just going to probably give them their mealtime. And then from there on, it's really just managing their normal blood sugar. I usually like to keep these folks in the ICU if they're admitted to the unit for a little while, just maybe get another check or two, make sure that things are going in the right direction. And then it's sort of like, peace be with you, go forth and prosper. The thing here, though, that I'm going to kind of end on, at least for this segment, is don't set your hospitalist colleagues up for failure. Come up with a plan, initiate that plan, make sure it's working, and then pass that along as you move that patient out of the ICU. Okay, Mick, take it away from me.
So what does good look like to me? Good looks like the absence of bad, right? So there's a lot of ways you can screw up, making their potassium fall too fast, having their gap reopen because you weren't careful. Those are mistakes, you don't want to make. So don't make them. And one of the biggest mistakes that I see people make consistently is they don't check labs frequently enough. It may seem like overkill, unnecessary, but I think in general, if somebody is sick enough to be in the ICU, they're sick enough to merit frequent monitoring. In some cases, that might even be like every 2 hours. If they're really sick, blood gas every hour. And the sort of art is gracefully de-escalating that into, Q4, Q6, Q8, Q-day. But I think it's, one of the most consistent mistakes that people make is they declare victory too soon, and then an anion gap reopens, for example.
Yes.
Another is they're not monitoring all of these parameters. So like the glucose is normal, but the anion gap isn't. Or maybe they've under resuscitated is another thing you see sometimes, where somebody is really reluctant to give fluid, and so the person's still pretty dehydrated, they're still pretty tachycardic, maybe they're even orthostatic at the end of your resuscitation phase. So I just think of it as like, you have sort of three pillars, three things you're following, right? And you have to make sure you've fixed all of them, and they have to make sure they stay fixed.
Perfect.
The last point I'll make, which I think is a good segue into how we want to close, is that this is a morbid mortal condition, right? Like I always tell people, like this is life threatening. Like there's a 1% risk of dying with this. I don't tell them that, but like when you admit somebody with DKA who can talk, I always want to pull up a chair and sit down and talk to them and be like, how can we prevent this from happening again? And I think that sometimes as the intensivist, it's kind of like, oh, it's a hospital's problem, that's a floor problem, that whatever. But I think it's our problem, right? Like this person landed in the ICU. We need to do what we can to prevent this. Sometimes the answer is, things that are hard to fix, like unstable housing. Sometimes it's things that are really easy to fix, like you ran out of test strips, you ran out of needles, you ran out of insulin. Sometimes it's things that are sort of medium hard to fix, like, oh, you don't have a PCP anymore. Like, well, I can't snap my fingers and write you for one, but we can get that process started. Every single time I admit somebody to the ICU with DKA, I wouldn't say every time, almost every time I get the diabetic educator involved.
That is a golden pearl.
I mean, there's almost always a knowledge gap here, which contributed to this. And so you can address that. I also think of this as like, in the trauma literature, they talk about like the teachable window, like when somebody falls off their skateboard and gets hurt, like now is a good time to talk to all their friends about helmets. This is kind of a good time to talk to people about, diabetes management in general. And so, I think like this might be a moment where people can like change behaviors that led to this.
Those are all great points. I think the one thing too that I'll say, and this is again deviating a bit from our overall mission here in critical care time, but your point about insulin, it's if you can afford it, it's an easy fix. If you can't afford it, it's not such an easy fix. And so I would implore our listeners, irrespective of your political leanings, I suppose, to just sort of like think about that when you're trying to be a patient advocate, and just think about the fact that the decisions that are made on high very directly impact patients' access to what should otherwise be pretty inexpensive treatment, you would think, that can really be life-saving and keep people out of the hospital, keep people out of the ICU. So it's really sad And I'm seeing this a lot more now in this phase of my life. It's just so sad when I see folks who are like, yeah, I couldn't afford my insulin because I had to feed my children. It's like, how do you react to that? How do you respond to that? It's just terrible and heartbreaking. So.
Right. The inventors of insulin, the discoverers of insulin, I should say, deliberately didn't patent it to make it more available. Right. And so here we are, a century later, and there are people who can't access it. Like that's a shame. That shouldn't happen. One other thing that I think about more and more is, are we have protocols to do this, but are we really being optimal about this? And one thing that I've been thinking a lot about lately is like, should we be using continuous glucose monitors in hospitalized patients with DKA? The idea is that, having a nurse come in and poke your finger and draw your blood and check it every hour. Well, first of all, if you ask the patient, they're going to tell you that sucks. That
Yep.
was their least favorite part of being in the hospital. Second, you're wasting a lot of stuff. You've got the pokey thing, you've got the alcohol, you've got the gauze, you've got the test strip, and then you're wasting a lot of time too. And then finally, you're waking somebody up to do that. Can you imagine, like, if you were waking somebody up every hour to poke them and draw blood? Like, they would hate you, right? But we like normalize this behavior in the hospital. So I've wondered about this. I think jury's still out on it. The issue is that those continuous glucose monitors, where there's like a sub-Q thing
Yep.
under your skin that measures interstitial glucose, they're definitely less accurate in DKA. They are not FDA cleared for use in this setting. So this is definitely an off-label use. But I kind of wonder if this would be better. There were a couple of pilot studies done during COVID when people wanted to minimize PPE use by going into the room so often, where they used continuous glucose monitors, and they found that they worked reasonably well. A couple small studies since then. I think the jury's still out, but I would love to see an RCT proving that this works. I think it's potentially cost saving too when you factor in all of the other consumables and labor. And I think it would be very beneficial in terms of patient experience and preventing delirium from sleep disruption. So anyway, that's something where I think there's a lot of opportunity in the future.
I think that's great points for sure. All great points. There was one other thing, Nick, that you'd mentioned, and I don't want to leave the audience in the lurch, but this idea of like, from your perspective, who can be treated with subcutaneous insulin, who really needs to be on the drip. Do you want to maybe close out your sort of final thoughts by fleshing that out?
Yeah, so I think that's another area where there's been some progress in recent years. I think it used to be that DKA mandated the ICU because everybody with DKA needed an IV drip, which means you needed Q1-hour glucose checks, which means you need an ICU nurse. That's not a great use of resources, and that's probably unnecessary, particularly for some of those people with mild DKA. So there have been a couple studies recently that show that just starting off with sub-Q insulin, depending on the person's response to it, may be an adequate way to treat it. There was a Cochrane review a few years ago, actually, I think 10 years ago, which found that in the right patient population, like mild DKA, this is enough. I think the area where there's been some evolution in the last decade is, maybe moving into some of that moderate group. There are people where like they're relatively mild DKA. They don't have something else that caused it that needs to be treated in the ICU. They've responded really well to the initial phase of therapy in the emergency department, and maybe they don't need an ICU bed. I think it also depends a little bit too on what your hospital is like. Some hospitals have step-down units that are like, a big hospital step-down unit might be like an ICU at a small hospital. So I think it kind of depends what the levels of care really are granularly, like how often can you check a glucose. But one thing that I'm hoping for, and maybe some listener will do this RCT for me, is, could you achieve higher safety by avoiding hypoglycemia in those settings by using things like continuous glucose monitoring? Because there is some evidence that CGM is better at detecting hypoglycemia among inpatients, which is really what we care about. Like, I don't care if it's inaccurate for highs. I care that it's capturing lows, and being able to get a reading every 2 minutes as opposed to every 2 hours is probably safer from that perspective. I'll step off my soapbox now.
All right, guys. So thank you for bearing with us during this kind of somewhat lengthy, but I think very informative, comprehensive, and hopefully useful episode where we talked about primarily DKA, but discussed some of the other ketoacidoses. Some kind of bottom line teaching pearls from me, and Nick, if you have any others, please do chime in. But I would say, DKA is not just glucose above 250. plus ketones. It's a little more nuanced than that. That beta hydroxybutyrate is really important. So make sure that you're checking those in your patients, as opposed to watching the urine, ketones or the urine glucose or the serum glucose. Really, the serum glucose is almost like a surrogate for where you're going, but it is definitely not the primary goal here. Treating that is not the primary goal. We want to improve that acidosis. We want to resolve that acidosis. And some of the other pearls I'll mention is really that potassium. Like, watch it. Do not start insulin until that potassium is repleted. And by repleted, I would say above 3.5. Crystalloids. I like balanced crystalloids. Nick likes balanced crystalloids. If you give the person NS, it's not going to be the end of the world, but I think there's good evidence now to support kind of swifter resolutions, better resolutions when you're using a balanced crystalloid. And finally, I'm going to say,
if you give NS, just know that I'm frowning and shaking my head and disapproving of you.
Yes. Well, both of us are in unison. And finally, those special populations, be mindful of them, and especially those that are at risk for euglycemic DKA. Again, up to 10% of your cases of DKA may be euglycemic in nature. Pregnancy portends a risk, as do, of course, those SGLT2 inhibitors. So just be on the lookout. And just, we didn't necessarily mention this right away, but if you are managing euglycemic DKA, the probably fastest way to summarize that therapeutic approach is it's basically like you're skipping phase 1 and moving on to phase 2 of therapy. And you're kind of starting there.
Yeah.
Nick, any other final points before we do our
I'd sort of walk through my approach to this. So the first question of, is it DKA versus is it a different ketosis? So thinking about euglycemic DKA, alcoholic ketoacidosis, starvation ketosis, and then that overlap condition with HHS. So that's question number 1. Is it really DKA, or what is it? Question number 2, what's causing it? Think about the 5 I's, the sort of root cause questions. Even if it's insulin deficiency, why did they run out of insulin? Third point is think about your 3 pillars and your 3 phases, right? Make sure you're addressing all of them. And remember that DKA, even though it's routine, everyone's a little different. There's always going to be exceptions. Frequent monitoring is key. I always tell people in the ICU, the key to being good at the ICU is measure something, do something, measure again. That's the essence of good DKA care. We're measuring
100%.
labs, we're doing the 3 pillars, we're measuring again. And then, hopefully people are moving kind of smoothly through the different phases. And then finally, just a plug for, yes, this is something we see all the time, but don't be bored by it, treat it well, try to make this the last time somebody has DKA. That's your goal.
If you guys want to learn more about this, you should check out our website, www.criticalcaretime.com. We have our show notes there. Nick is likely going to cross-post his one-pager there, which is really an incredible resource. While you're there, make sure
an anion gap calculator that can help you out there.
That's right. We got that as well. And we're always adding tools, not just Nick and I being tools, but we're also adding tools to the website.
Like toolbox tools.
Yes, correct. And of course, if you do go to our website, which we encourage you to check us out, subscribe to our mailing list, leave a comment. We really appreciate all of that.
All right. And now we've come to the part of our show where we like to say thanks. Thanks to our amazing listeners, those who have left us reviews, 5-star reviews in particular. Thanks for getting the word out about our show. Thanks to our production team over at Podpaste, who edit us and make us sound good. Thanks to Kurt Belknap for the awesome theme music you're hearing right now. If you have not already, please share the show with other people. Be sure to subscribe, give us a like, subscribe to our mailing list, do all of the things to help others learn.
That's right. And make sure to leave us a 5-star rating. And after you've done that, give us a holler. Okay. So we're on X at Crit Care Time, or Nick M. Mark, Askins_Razor, if you want to reach us individually. We're on Instagram, LinkedIn, Blue Sky, Threads, YouTube. Some permutation of Critical Care Time will get you to us.
Yes. And now disclaimers. The views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarity to real world cases are purely coincidental.
And remember that this podcast is for educational and entertainment purposes only. It is not medical advice, so don't use it if you're seeking medical advice. Talk to your doctor.
If you've got DKA, don't turn off this podcast and actually go to the hospital.
That's a great idea. With that being said, I'm Dr. Cyrus Askin. It's been my pleasure to talk to you guys today. So long until next time.
And I'm Dr. Nick Mark. See you next time.